Hello, everyone. Welcome to the CCIH 2022 annual virtual conference. I'm Mona Bronnert, the program director at CCIH, and I'm so glad you could join us for today's last day of the conference. So you will see a slide with instructions in French and Spanish to join the language interpretation channels. Today, we will be having speakers in English and French. So it's very important that you choose a language to listen in. And if you are new to CCIH, we are a global network of approximately 120 Christian organizations and 15 secular partners, as well as a few hundred individual members. Our mission is to promote health and wholeness from a Christian perspective. And we provide opportunities for capacity building, networking, sharing best practices, and advocacy. So glad you could join us. And thank you to all of our conference sponsors. Your support ensures that we can hold our annual meetings to come together for sharing and learning, discussion, and fellowship. So thank you so much to our many sponsors. And just a few housekeeping pieces. We'll hold all questions until the end of the program today before we go into networking and breakout rooms. So at approximately 10:20 Eastern time, we'll collect all questions until then. So please use the chat box to ask your questions. We have staff monitoring that, and we'll let Evelyn, our moderator, know what the questions are. The session is being recorded and will be posted on CCIH's YouTube channel in our conference playlist. And you will also find links to the recordings on our website at ccih.org under events. And we encourage you to join us in sharing what you're hearing, anything interesting or helpful based on what the speakers are saying on social media. We have these fun hashtags, CCIH 2022, faith-based and global health. So love to see the discussion on social media also. I'm very pleased to now turn it over to our moderator for today's session, Evelyn Gathuru. Evelyn is a monitoring, evaluation, and learning officer at the Christian Health Association of Kenya, and she supports maternal and reproductive health programs, NCD programs, and health system strengthening programs. So very grateful to Evelyn for moderating today's session, and I will turn it over to her. So welcome, Evelyn.
Thank you, Mona. Good afternoon, good morning, and good evening, everybody. Thank So as I was, thank you for joining us. Good morning, good afternoon, and good evening. Before we begin, let us begin with a centering prayer. Dear God, we thank you for giving us the time to meet today and to discuss this important topic of localization. We ask that you may bless our speakers and our audience, and that the information and discussions we have today may help strengthen our work that we do to improve the health of the people that we support. In Jesus' name we pray. Amen. Thank you once again for joining us today on the sixth and final day of CCIH's annual conference. Each day we are focusing on a theme of learning our neighbors. Our theme for today is localization of health, what is necessary to ensure healing and sustainability. This is an apt time for us to pause and reflect on localization, as organizations from the Global South need to play a greater role in owning and leading their development. It is important for us to recognize and to utilize the wealth of knowledge and skills that lie within the Global South. It is also important for us to keep sustainability in mind as we move towards this model of development. Our speakers today will help us consider what this looks like practically as we explore these evolving dynamics. As you listen to the presentations today, I encourage you to think about some of these key questions. We will go into breakout rooms later on, and we will talk about these questions. Our first question or area to think about is the progress in localization. Are we making progress in improving local authority and control over donor-led programs? How do we know this? And is it helping or hurting progress? The other area to think about is working with international NGOs. What are the do's and don'ts of localization when international NGOs try to support the growth and capacity of local organizations? And a final area to think about is sustainability. How can programs build sustainability where complex program elements, dependence on external technical expertise, and the lack of local resource mobilization pose barriers to local ownership? We will now go into the presentations for today. We will start our day by hearing from USAID's Local Capacity Partnership Advisor, Ariella Camara, who works in the Office of Country Support in the Global Health Bureau, supporting the New Partnerships Initiative Unit. She also co-leads the Bureau's locally led development and government-to-government working groups. Welcome, Ariella.
My name is Ariella Camara. I am with the Global Health Bureau and help to lead our new partnership initiative and localization efforts. On behalf of USAID, I will be providing remarks today. Good health outcomes are achieved when families and communities are proactively engaged in their own well-being. At USAID, we believe fundamentally in supporting individuals, families, communities, and nations on their own trajectory towards sustainable health outcomes. From our perspective, localization encompasses the processes and actions that USAID will undertake to ensure our work puts local actors in the lead, strengthens local systems, and is responsive to local communities. Localization is an institution-wide change at our agency. It's not just a set of targets, it's a new way of doing business. Localization at its core is about changing relationships and power dynamics so that local actors are at the center of our work. To do this, we will need to continue to change our attitudes, behaviors, practices, and procedures. Localization is also closely linked to USAID's inclusive development approach, which ensures that all people, including those who are marginalized or underrepresented, are fully included and can actively participate in and benefit from development processes. USAID's administrator power established two important goals for localization. By 2030, our goal is that 50% of USAID's activities across our development and humanitarian portfolios will put local communities in the lead to co-design a project, set priorities, drive implementation, or evaluate the impact of our programs. And by the end of fiscal year 2025, at least a quarter of all of our obligations will go to local organizations, excluding operating expenses, personal service contractors, government to government, and public international organizations. Building on our previous efforts, USAID's approach to localization will have four overlapping lines of effort. We will shift power to local actors by integrating local voices and leadership into all aspects of our programs. We will channel a larger portion of assistance directly to credible local partners while ensuring accountability for the appropriate use of funds and achievement of development and humanitarian results. We will apply local capacity strengthening efforts and local systems in pursuit of locally led development. And we will serve as a global advocate and thought leader on localization. In alignment with our efforts, we would like to recognize our partnership with CCIH and other faith-based local organizations. For example, through our Momentum Country and Global Leadership activity, CCIH developed a global social and behavior change toolkit to engage local faith actors and ministries of health in boosting COVID-19 and routine immunization uptake, and to address barriers that prevent faith communities in particular from accessing vaccines. Also through the new partnership initiative, the Strengthening Community Health Outcomes through Positive Engagement Activity, also known as SCOPE, through World Relief and CCIH are working with local partners in Malawi, Kenya, and South Sudan to train health workers at facilities and within communities to improve health outcomes. In addition, the African Christian Health Association platform, also known as HF, and their local partners trained more than 1,300 community health workers on integrated maternal child health and community-based distribution of family planning in Kenya and Uganda using in-person training and continuous mentorship. USAID is also working on finalizing a new local capacity strengthening policy by the end of the summer. We would like to thank CCIH for their extensive feedback on this draft policy. USAID will also release a report that will summarize all the feedback that was received and the changes that were made for the policy. We are also in the process of creating the first of its kind strategic religious engagement policy. It will build upon the agency's efforts to strengthen the evidence base on religious engagement in development and ensure we work with individuals and organizations embedded in local communities. We expect to release this for public comments in the next few weeks and look forward to CCIH's input. Over the last decade, USAID has made changes to how we seek and form partnerships with local actors, including recently the launch of workwithusaid.org. We also continue to value our partnerships with CCIH and look forward to continuing collaboration and moving forward with our localization efforts. Thank you.
Thank you, Ariella, for sharing with us. Next, we will hear from two speakers about the Global South's local NGO Emergence, where emerging independent organization survived the Global North's NGO Proxies as the new local organization. Our presenters today will be Reverend Troy Lewis and Nkatha Njeru. Reverend Lewis is the co-founder and executive director of Expanded Church Response, ECR. He's lived in Zambia for 20 years, serving with partners to help the network, help network the church and awaken its potential to be a Christ-focused, holistic, transforming agent for individuals and communities. Nkatha Njeru is the coordinator and CEO of the Africa Christian Health Association platform, ACHA, which is an umbrella organization for Christian health associations with membership in more than 30 African countries. Welcome so much, Reverend Lewis and Nkatha. Glad to have you here with us. So to start us off, I'm going to ask Reverend Lewis, could you briefly give us a background on the changing dynamics in the development space as you've seen it with respect to Global South's ability to take on major role of facilitating their own development?
Okay, thank you so very much. And I want to thank all here for this opportunity, and especially CCIH. I guess just to get to the time is short, just to get right to this. HIV/AIDS here, especially in Eastern and Southern Africa, for 20 years has colored development and health here to an end for incredible gains and transformation, particularly after the establishment, particularly starting during the peak of the HIV/AIDS pandemic, and getting us to near epidemic control in many places, especially through Global Fund and PEPFAR, which has been a godsend to these places. Starting in that time, here, some of the large NGOs came together and formed a consortium here in Zambia to start an amazing initiative for orphans and vulnerable children, prevention, care, support, and treatment. USAID was one of their first large PEPFAR grants here through this project here, and it required the project to build the capacity of local partners. And ECR was chosen to be the national level local partner for the internationals to build their capacity, and will connect with the community partners working on the ground to implement the project, mostly through these community partners and building their capacity. Many of these were faith organizations on the forefront, embedded with long-term commitment at a community level. The international started with building the capacity of these locals and ourselves as nationals. And many of these locals started out having accounting with receipts and shoe boxes and lacking technical capacity, M&E and all of that, to being moved over these first 5 years to doing budgets in Excel, reporting, policy documents, project plans, all of that, the regular systems there that we're used to even worldwide. And so what's happening, that was game changing, not only for the locals, for them building their capacity, and then also their capacity through savings groups and other things to see about how we can begin to make the local sustainable. But ourselves as ACR, as a national local organization, and that's independent, to seeing about where it's transferred over to us, the capacity building for these locals that were embedded in communities. We had almost 7,000 volunteer caregivers through these communities and all this that was happening there. And so what we've seen happen after is what's been happening lately as USAID and the PEPFAR has been focused on the local organization. International NGOs are coming in and they're planting their proxies attached to their headquarters. And right now that's causing a major problem because what's happening, these are competing with the locals and taking resource, with their well-resourced machinery in terms of able to compete better for these proposals. And it's also in terms of taking the staff when they come into communities from these locals, and the locals basically have no say and are basically wilting right now. And in terms of wondering and the type of progress that has been gained with these locals and owning their community problems, right now that is very much in terms of at risk.
Thank you so much, Reverend Troy. Why do you think it's important that we consider these issues at this moment?
Right now, I think we have to look at what is our goal? Is our goal just to sing about working on projects and meeting targets from project to project? We're looking at here in Africa, the major cities exploding in growth. That's not going to be a sustainable model, but what's going to be sustainable is seeing about us building as far as about the local capacity, and particularly as you're working with faith-based, with their own networks on the ground and all of that, and the capacity there, when the project pulls out, we have seen these organizations go on and continue. But what's happening is that have a mindset change where they're taking responsibility for what's happening. We need this type of transformation where the countries want to sing about helping people help themselves and not be depending on as far as about from these others that come in that are in the community during the project and have to pull out when the project ends. And so it's looking at right now the sustainability there that is at risk in these different models.
Thank you. Nkatha, this can be a bit of a sensitive issue. Could you speak on how you navigate this space while balancing the need for organizations in the global south to have a voice and a sense of agency while maintaining good relationships with the global north organizations, including their proxies, as they continue to support development in the global south?
Thanks, Evelyn. I think that for us at the Africa Christian Health Association platform, we are one of the examples of localization, having just recently started working with the US government on as a prime of a funded project by the US government, and previously not having had any experience working with the with that magnitude of funding. I think for us, one of the how we navigate this space, I think we have to first of all ensure that we are seated at the table, and we clearly present what our priorities are from where we sit and how we see them, and have a discussion. Of course, like I will say later, there has to be a willing partner from the global north that is ready to listen and talk and understand what our strengths are and what we would like to do and how we would like to do it. But I think just making sure that we are seated at the table and presenting our priorities as we see them has been one of the biggest goals for us, to be able to present ourselves as organizations that are leading our own development.
Thank you so much, Nkatha. What do you see is the role of the Global North, as well as the funders and the donors, as we support the Global South to have a voice and role in championing their own development?
I think the first role is that organizations in the global north need to be proactively walking the talk, that they need to be leading in allowing the global south to lead their own development, make choices of their priorities, and actually be advocates at whatever level they are, provide meaningful engagement and supportive of these initiatives. Because like Troy has said, a lot of what has happened in the past has been that development has happened through projects that are written and brought, and people put in proposals to do what was proposed on the project. So we have to write in that manner. But the recent engagement and drive towards localization, where organizations are asked to actually, we are asked to propose what our priorities are and actually led to lead our own development. And not just be consulted or informed, but be partners in that development and ensuring that whatever the priorities are is actually what goes into the co-creation of that process, is what I would consider as a priority in the global north championing localization. Thank you.
Thank you so much, Nkatha. Back to you, Troy. What do you think should be considered to move developmental change and transformation in health to the next level?
No, thank you for that question. One of it, I think several pieces of it, is that as we look at, oftentimes when we look at health, I think for health professionals, they specialize in that. But what's happening is that the people in the communities, health, while we're looking at health, health is also very much tied to economics. Economics as it relates to people being able to get, whether they can get medicines or get the care that they need, but also economics for the local aid, for the local organizations that are delivering services, particularly the faith-based. And what we've seen is that as we give them capacity, whether through community savings groups and through to starting businesses to cooperatives, we've seen so much has happened with that where they have become able to develop the economic support to help sustain their orphans of vulnerable children in their own communities and helping provide care and helping support the caregivers who are volunteers to support themselves. But one of the things that we see sometimes, I think, along with that, as far as about looking at how is it that we build capacity for not only just health, but economics, but a commitment from the donors who started working with particular building capacity of those agents that are in communities, multiple agents that are in communities, to seeing about keeping a commitment towards working with those along a course of development till they get to the point where they can support themselves in this type of way, technically, as well as economically. And another is, as far as about that, we're seeing about how is it there that as the internationals come in, there's definitely a role for the international organizations. We wouldn't be where we're at right now without the international organizations. But part of it is looking at the international organizations coming in not to compete against the locals, not just seeing about taking their staff to furnish their staff, but just seeing about how is it there that instead of just looking at relief and targets, how is it that we think more along a Marshall Plan as it relates to seeing about these communities and these places there being able to be self-sustaining and having their capacity built and walking with them through this process there. And so those are there's a lot more, but I'll stop there because of time, but those are some of the pieces there that I think that we need to look at there, particularly health and economics there and building that capacity for the locals, the national locals that are there on the ground and embedded in the communities. Thank you.
Thank you so much, Troy. Let's have the same question for Nkatha. How do we move the development space to the next level?
Well, I think Troy has said much of it, and for time's sake, I think I'll just say that there's also a need for deliberate skills transfer. So that we are sitting on the table and having discussions like that are not looking at development in terms of competition and who's holding what, but that we are deliberately transferring skills and supporting one another for the sake of communities that we serve. I think also being able to allow the locals to set agenda and changing the way we do funding, so that we start, we are not, it's not a top-bottom approach to funding, but we start far ahead of time and look at communities and go to communities and discuss the priorities in communities, and then set the agenda of the project from that end. And then we can together be able to run projects that will be sustainable and that communities can take on, and especially the Global South. Thank you.
Thank you so much, Nkatha and Reverend Troy. Those are such interesting and insightful discussions that we've had. Thank you so much. Next, we're going to transition to our next speakers, where we'll be hearing from lessons over 100 years of faith-based healthcare in Ghana, as Peter Yeboah interviews Dr. Ben Walker. Peter Yeboah is the Executive Director of the Christian Health Association of Ghana, which is the largest and oldest non-state provider of health services in Ghana. He is also the chairman of the African Christian Health Association platform, ACHAP. Dr. Benjamin Walker has been a teaching fellow at the University of York and also led a project for planting new Christian communities, raising leaders, and reaching younger adults in the Diocese of York. He is now the Strategic Program Manager for the Diocese of Leeds. Welcome, Peter and Ben.
Yes, many thanks, Evelyn, and a very pleasant, warm greetings from Ghana. With much pleasure, I am very happy to engage in a very exciting conversation with Ben, who has had a wonderful and epic work on the religion in global health and development, the case of 20th century Ghana. Ben, let me quickly extend my heartfelt congratulations. First, on tracing the history of religion in global health and development. And secondly, choosing Ghana as a place of destination. Congrats once again.
Oh, thank you very much, Peter. I mean, it's been probably about 8 years of work now on this particular project, involving lots of different kind of archives and interviews all around the world. And as Peter was saying, it's just been published only this last May, which is really exciting. And actually, only this morning has it been released as an ebook. So this very morning, you can actually, so I'll put it in the chat, you can get access to it. And right now, for free, you can now get access to it. We had trouble getting it to Peter over the last few weeks. And I think there's it's pushed some action in the publishers. So now you can actually get it free right now through the link that I just put in the chat. And if you want to find out more links or get other ways of accessing it, you can add me at Ben_B_Walker on Twitter.
Thank you very much. Many thanks for your charitable offer, certainly in the spirit of Christian connections for international health networking. Ben, let's get back to the theme of your book. Indeed, for many years, we, the younger generations, have no sense of history about the role, contributions of religion, both at the global level and country level. And so tackling or addressing the history of the relationship between religion on one side and global health and development on that other side is very much exciting. So my first intriguing question would be, to what extent are these historical perspectives offer global health and faith-based organizations some paradigm for future engagement? Tell us, what is the relevance of history to global health?
Well, I guess that's the big concern that drives my work, is the way that religion and global health relate to one another. And as a historian, the way that I answer that question is by looking at how the legacies from the last century extend and shape this one. Because actually, patterns can last a long time. I mean, it's not only do structural injustices, geographies of extraction and exploitation, but also sources of labor, specific streams of development funding, even particular individuals, can last many decades in global health and in religion. And so when we approach some of the hardest questions we've got in health politics and economics, interrogating their histories actually provides a vital route to solutions. And so that's why I did this extensive and original research on this question, and particularly on Ghana. Because often histories, they just focus on high-level policy making, and then they imagine it like that works its way down to the ground. But actually, those histories don't extend beyond DC or Geneva, and they imagine global health all around really WHO as though it's like a celestial body where everything is drawn in or is born out of. And actually that limits the frame by which we understand healthcare, because it makes it sound like it just happens in the offices of departmental heads in WHO. And yeah, decisions are made there, but that erases a diverse range of people who produce health in its meanings. And sometimes that really neglects the role of religion, especially, and Christian mission. Sometimes that's an active secular bias, sometimes a dislike of taking local politics seriously. But I think often it's an ingrained Euro and American centricism. And so I only last week did I see at the British National Health Conference, Health Service Conference in Liverpool, the historian David Olusoga talk about, it was a keynote speech, and he talked about how poor policymaking and official judgments happen because of a lack of understanding between historical relationships. He talks about the relationships between Britain, Jamaica, India, and Barbados. And he said, when we marginalize certain histories, such as immigration and healthcare, because they seem a threat, we can't fully comprehend the journeys that brought us together.
Wonderful. That is a wonderful global perspective about how the narratives of the history of faith-based has been shaped. But definitely, I take it that local context is very necessary. And this is where we have to move from global level to Ghana. I mean, you're the center of your case study. And so I just want to find out your fascination with Ghana. To what extent has Ghana, in terms of leadership and governance, how has Ghana led the faith-based health system throughout? I mean, any exciting revelations about leadership and governance style, looking back into the history of Ghana and China?
I absolutely love that question. And the reason I love that question is because most histories talk about triumphant stories of WHO or aid organizations in the West. And I want to emphasize that Ghanaians themselves made global health happen. It didn't just happen to them, like often stories get told. So local community leaders, religious figures, post-colonial nationalists, lots of different kinds of Ghanaians drove global health. There are some that maybe you'll have heard of, like Fred Tsai, who was the head of the International Planned Parenthood Federation, or Felix Konotia-Hulu, a famous malaria doctor, or Mary Grant, who works in the government of Ghana. But there are many others. Here's just one. Okay, the young Ghanaian epidemiologist, Frank Grant. He was young in the 50s. He's no longer with us. But in the 50s, he was just starting out. He was probably one of Ghana's first epidemiologists. And he became the head of the smallpox and measles control program when it began in 1965. And he was so important, not only in controlling and eradicating smallpox in Ghana, but around the world when he joined WHO expert committees, when he did it in lots of different countries and supported their smallpox eradication. But he didn't do this because he was told to by kind of outside aid organizations. He drove the initiative from below. There are some interviews with USAID program officers in the 60s who say that Frank Grant forced their hands in getting the program started himself. There's a great story of one called Fred Gilbert who says, Frank had a message and said, maybe we should talk about this. And that was a pain in the neck. It meant that I really had to read the thing. It was clear it wasn't going to go away. It was coming at us 100 miles an hour. And then he says, so we want up an agreement financed by AID, sponsored by WHO, implemented by CDC, fitting no model or guidance. And it ultimately turned out to be a good, even fun experience because Frank Grant was such a good guy. And what Frank Grant was doing, so he was the son of the head of the Methodist Church in Ghana. He was a Christian. What he did was he intermixed global and local identities to gain trust and support from multiple levels of stakeholders. He knew communities. He also knew medical officers. He knew the police. He knew parish priests. He knew local Catholic churches. And he co-opted all these into the vaccination program. And what we learned in Ghana from that is part of the story of how smallpox was then eradicated worldwide, where faith and health were entwined in the work of this incredible Ghanaian.
Absolutely. I can really sense the passion, and it's much more exciting to recognize Ghana as the cradle of probably global health, development. But in your submission, I hear something of funding stakeholders, and that leads me to the next question of interest. In your book, I've had a chance to read aspects of it. You acknowledge that, quote, the amount of religious assets that includes hospitals, clinic, dispensaries, constitutes between 40 to 50% of national health systems, especially in my country and other global and African, countries. Meaning that definitely funding has been very relevant, and certainly non-Ghanaians, expatriates, missionaries have been very instrumental in helping to establish faith-based health systems. So tell us, to what extent have been non-Ghanaians, expatriates, missionaries been very instrumental in funding the faith-based architecture and health infrastructure of these countries, and any particular countries that have been so prominent in this whole enterprise?
That was one of the really striking and surprising experiences of doing this research over a few years, was that I found that especially Germany and the Netherlands were funding Ghanaian healthcare in massive, massive waves of funding from the 1950s, from many decades on from that. And there were lots of reasons for that, and you can explore them in particularly the third chapter of my book, and I won't go into them now, but they were about post-war renewal in Europe. But as well, the US often were linking faith-based healthcare to their big food relief funding. So a USAID report in 1996 said that between 1965 and 1994, Ghana received $340 million in food aid. Now, that was the second largest country receiving food aid who was not at war. So it was a huge amount. But what we don't often hear about is how did they do that infrastructurally? And it was all through faith-based organizations. It was through the clinics, the dispensaries, the hospitals, but also through the churches that they actually distributed that aid work. We actually can't understand some of the biggest successes of global health over the last 60, 70 years without understanding that fundamental infrastructure that faith-based healthcare provides. That's not only in smallpox eradication or only in food relief, but in many other programs and initiatives. So there are big questions over what that looks like in the future. But I think when we look at the past, we can really see that there's that intertwining of global health and faith-based provision is just simply inseparable. And when it is separated, we can no longer understand why global health works.
This is very much exciting. It is always fair to acknowledge the exceptional contributions of our partners who contributed ideas, resources, funding, and then voluntary contributions to making the faith-based health system what it is today. And very much exciting acknowledging Ghana once again. I'm naturally biased and excited, but to be very realistic, I have been in the Ghanaian health system for the past 28 years. And when I see the passionate and the excitement about our contributions, I mean, I'm highly inspired, and yet I have to be very realistic. There are obvious challenges, there are limits, there are issues that we grapple with. In your over 100-year perspective in reviewing the health system, what are some of the notable challenges and issues that you really identified, which will be of relevance to our present circumstances and our quest to move into the future in a future positioning?
Yeah, I love that question as well, Peter, because when we care about something, that doesn't mean we shouldn't challenge it or critique it or seek to understand it more deeply. You know, as the Christian Medical Commission of the World Council of Churches in the 1960s asked, how does our story of health that we're creating tell about who Jesus is? And that was a big challenge, because I think one of the big issues with faith-based healthcare over a century was the focus on hospital provision. And hospital provision told the story that Jesus is miles away from you, that though he will care for you when you get there, you might die on the road. Whereas primary healthcare, which hadn't yet been invested in loads at that point, could alternatively say, he comes to you, he comes into your situation, into your chaos, and meets you as you are. And I think that's because before the 1960s and 70s, one of the patterns that had been set by mission was to focus on hospitals because they were places where we could build trust. So you could, for a sustained and protected period of time, you could build relationships with communities, especially for expatriate missionaries. But African newspapers in the Gold Coast in the 30s and 40s were complaining about sanitation, but nothing much was done about it because hospital building had been focused on instead. And again, before this, missions and Christian health organizations often invested in maternal and child health. But when the focus went to hospitals, that reduced. So in Ghana, between 1952 and 1954, the death rate of women in childbirth increased from 18.4 per 1,000 births to 21 per 1,000 births. The medical report in 54 also said there's been no real improvement in infant mortality in 20 years. And a big part of that is because mission stopped emphasizing maternal and child health, which had often created some of the best medical provision in the world, like it had in Uganda. And this has sustained legacies for today. Still, there are many places in desperate need of investment in maternal and child health. And actually, instead of focusing alone on trust building, we can focus more on the majority. Actually, missions sadly didn't invest in the long term in this, and therefore we need to more today. But I think, again, that comes back to our question. What story are we telling of healthcare that tells a story of who Jesus is? What kind of stories are we telling? Not just in the why we do it, but also in the how we do it.
Wonderful. It's good always to recognize missed opportunities and failures as pointers for further engagement. I think as we come to the end of this exciting conversation, taking a look back into the future over a 100-year period, a century, naturally talks about legacies. So in all your wonderful work, what are some of the legacies in terms and their implications for global health policy development and faith-based health systems? What are some of the pointers in terms of legacies, in terms of impactful changes and challenges in the system that you could contemplate? Please, legacies are very exciting and global audience are watching. Tell us some of the pointers, please.
Well, I think there are many, but one of them is that actually faith-based healthcare has lasted. It has endured because it's been adaptable and resilient. Ghanaians and missions and Ghanaian missionaries changed how global health was understood and created. They were a key part of how it's been formed. And they therefore, when international trends maybe went in a different direction, actually that voluntary sector, that sector of healthcare in Ghana, which is faith-based, could adopt programs that internationally weren't of interest, like primary healthcare in the 80s, which was happening all over Ghana, but not maybe in other places at the same time, because actually the strength and resilience of that sector was so powerful, even amidst economic crisis. And I think that decades-long presence actually lasts today. And so, I mean, another big thing though, that when I look over it, is actually having mapped out some of this story, I think there's so much more out there that could be understood. Yes, okay, so at least 42% of Ghanaian healthcare is run by faith-based organizations today, and it's many in other places as well. Percentage is going to be even higher. But actually, I've only looked a little bit at what are some of the voices that created that, and there are many more out there. Ghanaians themselves have been creating global health for a long time, and they will continue to do so, but many voices get neglected. And I think some of my book simply illuminates how much more out there is to discover. But again, to conclude, finally, I want us to come back to that question. We need to think carefully about the long-term story our healthcare is telling and how our histories are pointing to the beauty of the kingdom of heaven and to Jesus' redemption of creation. How is our health work telling a story of who Jesus is, and who or what is being left out of that story? You know, we see these long-term patterns which continue to ensure that the majority of the world's population have poor or no access to health. If we address those historic processes that continue to sustain injustice, I think together we can start to tell a new story where there are more voices and more people empowered.
Then I cannot tell you enough for highlighting the distinctive roles, contributions, and relevance of faith-based health systems over. When I hear things like adaptability, resilience, and equitable social inclusion, and promoting Jesus Christ healing ministry, I think I feel far relevant in this time when we are trying to shape a health system that is supposed to be responsive, inclusive, and resilient. Many thanks once again, and I want to believe that architects and friends will continue to engage you. And thanks for giving us the book to learn more and to be better promoters and advocates of Jesus Christ healing ministry. Thanks once again, and congratulations for the leadership and history of faith-based health systems. Congrats.
Thank you so much, Peter. Thank you so much for your encouragement and support. It means a lot.
Fantastic. Blessings. And friends, it's been exciting talking to Ben, and you are just a wonderful champion of faith-based health systems. Thanks once again.
Thank you so much, Ben and Peter. I think that was a really interesting and insightful conversation. What really stood out to me was that we don't even know our histories and how much histories are able to shape the power dynamics, and think about how we think of the development space and thinking about how to decolonize our narrative. It was really interesting because as an African, I didn't even know the story of Ghana and how it's leading the healthcare changes, because the narrative that we usually receive is a very Eurocentric and American-centric, like you said. I think that was really interesting. They should be teaching us more of this in schools, or we should at least know our history as Africans, and it took Ben to come and tell us about that. So thank you so much, Ben and Peter. Let us, we're going to going to our next speaker, and next we're going to be hearing or learning about strengthening capacity, the do's and don'ts in the local context, with an example from Senegal. So William Mui is a program manager at World Faith's Development Dialogue and primarily supports projects on maternal and child health in West Africa. She served as a Peace Corps volunteer in southern Senegal from 2010 to 2013, working with local communities on a variety of health topics. Ibrahima Etia has been a consultant working with CRSD since 2018 as a communications consultant. He is an information and communication specialist with in-depth expertise and 15 years experience in research, management, leadership, at both national and international levels. Wilma and Ibrahima will be presenting in French, and if you need to hear their presentation in English, please go to the bottom of the screen where you'll see the translation button and click on English. Welcome, Ibrahima and Wilma.
Bonjour, bon après-midi, bonsoir à tout le monde. Je m'appelle Wilma et je suis avec mon collègue Ibrahima Etia. Aujourd'hui, je vais présenter un peu de l'histoire sur le CRSD au Sénégal, et puis mon collègue Ibrahima va discuter spécifiquement sur le volet de médias. Next slide, please. Next slide, please. OK. Le cadre des religieuses pour la santé et le développement, ou bien CRSD, a fondé en 2014. Et la raison pour réunir le CRSD était ensemble les familles religieuses, les associations islamiques et aussi les églises catholiques et luthériennes au Sénégal. Au début, c'est juste un groupe. Et puis, nous avons ces étape par étape, commencer avec un groupe jusqu'à une association. Et après, en 2020, CRSD était formé une ONG officielle avec le gouvernement Sénégal. Dans notre travail, nous toujours parlé de renforcement des capacités. Et nous sommes toujours en communication et discussion sur les besoins de l'organisation et la meilleure façon que nous pouvons leur soutenir. Au début, on a focalisé sur 3 volets, les causeries, les visites de courtoisie et le suivi d'évaluation. Le CRSD veut travailler dans le volet de médias, mais ils ont fait très prudemment. Ils ont commencé lentement avec les spots radio et quand je parlais avec les chefs religieux, ils ont dit que le public n'est pas prêt de voir les religieuses parler sur planification familiale à la télévision. Pour nous, nous soutenons le travail de nos partenaires en décalant la prise de décision pendant la pandémie de COVID-19. Nos efforts de transfert de pouvoir et la localisation ont testé. Avec la situation qui était toujours évoluée, le CRSD ont pu continuer et adapter leur travail sur la planification familiale. Et un aspect clé était le média. Avec une fondation très forte, ils pouvons décalanter leur travail sur le média. Et maintenant, je passe la parole à mon collègue Ibrahima.
Merci beaucoup, Wilma. Bonjour à tout le monde. Comme indiqué sur la présentation, on travaille depuis quelque temps sur la question de la communication et de l'information autour des actions du cadre des religieux pour la santé et le développement. Slide, s'il vous plaît. Voilà, donc comme Wilma l'a terminé, en fait, au début, les religieux ne souhaitaient pas trop se présenter devant les médias pour se prononcer sur des questions aussi sensibles que la planification familiale, parce que le Sénégal est un pays à 95% constitué de croyants. Donc, les religieux, aussi bien les musulmans que les chrétiens, ne voulaient pas trop se prononcer sur la question à la télévision, à la radio, etc. Mais quand ils ont constaté qu'il y avait beaucoup de désinformation et de manipulation autour de la question de l'espacement des naissances, autour de la question de la planification familiale, on les a convaincus, les membres du CRSD, les religieux, à pouvoir quand même jouer véritablement leur rôle sur la conscientisation des masses, sur la conscientisation des communautés, sur l'importance de la santé, sur l'importance de l'espacement des naissances, sur l'importance de la planification familiale. Alors, pour atteindre l'objectif, on a utilisé dans un premier temps les médias de masse, parce que les médias de masse sont très utilisés en Afrique de l'Ouest, au Sénégal particulièrement. Premièrement, la radio. Parce qu'au Sénégal, dans les coins les plus reculés de ce pays, dans les villages les plus profonds, dans les communes les plus lointaines, la radio est occupée. Donc, la radio est le principal média de proximité, le principal média à chaud de proximité au Sénégal. C'est pourquoi on a positionné la radio comme canal pour pouvoir atteindre les cibles. Alors, pourquoi la radio? Pour permettre également aux populations de pouvoir interagir avec les religieux qui animent ces émissions-là. Alors, qu'est-ce qu'on a fait? On a préparé les religieux à pouvoir intervenir dans ces différentes émissions radio. Donc, à travers des séances de débriefing qu'on a fait avec eux pour les préparer sur les techniques de communication de masse, sur les techniques de communication à la radio, tout en les invitant à bien maîtriser les thématiques. Alors, donc, on a pu organiser différentes émissions dans pratiquement toutes les régions du Sénégal, des émissions radio interactives. On a également utilisé la radio pour faire passer des appels des chefs religieux. Parce que quand vous venez au Sénégal, on a ici des confréries religieuses et les responsables, ce qu'on appelle les khalifes, les chefs de ces confréries religieuses sont extrêmement influents. Donc, on a enregistré ces chefs religieux, ils ont fait des appels pour que les populations puissent faire l'espacement des naissances. Donc, on a utilisé la radio pour faire passer les appels, on a utilisé la radio pour faire passer des spots. Et en plus de cela, les émissions interactives qui ont permis aux populations de pouvoir poser directement des questions aux religieux qui étaient à la radio pour expliquer l'importance de la planification familiale, mais en se basant sur des argumentaires religieux. Donc, ils ont pu convaincre les populations à travers des argumentaires religieux. À côté de la radio, un autre média de masse qu'on utilise et qu'on continue à utiliser, c'est la télévision. Parce que, il y a un boom médiatique au Sénégal. Donc, on a des télévisions nationales, une quinzaine de télévisions nationales et des télévisions régionales. Pratiquement au Sénégal, il y a maintenant des télévisions régionales. Dans chaque région, il y a des télévisions régionales. Et en plus de cela, il y a un nouveau phénomène qui constitue les réseaux câblés de télévision, qui constituent des télévisions communales ou bien des télévisions de quartier. Au Sénégal, pratiquement chaque quartier a maintenant une télévision. Et c'est un opérateur qui diffuse à partir de cette télévision-là des programmes qui intéressent la population de ce quartier-là, qui intéressent la population de cette commune-là. Alors, nous, on a utilisé ces télévisions-là, ces moyens-là, pour faire passer des messages. Donc, les religieux sont partis à la télévision, au niveau de ces télévisions-là, pour animer des émissions, mais également des capsules vidéo qu'on avait produites, qu'on a fait diffuser à travers ces télévisions-là. En plus de ça, il y a la presse écrite qui est très bien suivie. Il y a différentes interviews qu'on a faites avec les religieux pour qu'ils expliquent vraiment aux populations l'importance de l'espace. Les réseaux sociaux. Une bonne partie de la population sénégalaise utilise les réseaux sociaux, en majorité les jeunes. À 90% ou plus, tout le monde est connecté au Sénégal. Donc, on a utilisé les réseaux sociaux pour sensibiliser les populations. Et là également, d'aucuns se posaient la question à savoir qu'est-ce que les religieux font sur les réseaux sociaux. Et là, on a produit beaucoup de capsules vidéo, beaucoup de spots qu'on a diffusés à travers les réseaux sociaux. Et ces différentes actions de communication nous ont permis d'avoir un impact réel sur la population. Et on a pu constater cela parce qu'aujourd'hui, le taux d'utilisation des services de planification familiale a nettement augmenté, surtout dans les régions les plus reculées, et cela grâce aux interventions du CRSD, grâce aux interventions qu'on a pu faire à travers les médias. Slide. Donc, ces différentes interventions à travers les médias ont permis vraiment d'avoir des résultats assez probants. Donc, sur ce slide-là, vous verrez les statistiques, les émissions qu'on a pu organiser partout au Sénégal, le nombre d'émissions qu'on a organisées, le nombre de personnes touchées, les capsules, les publi-reportages qu'on a pu donc organiser depuis 2019, 2020, 2021, les différentes capsules donc, et toutes les productions qu'on a faites au Sénégal et qui ont été diffusées sur l'étendue du territoire national. Aujourd'hui, le gouvernement du Sénégal se glorifie des avancées qui ont été notées sur la question de l'utilisation de la planification familiale, et cela grâce au travail des religieux. On sort d'une conférence nationale au mois de mai dernier, une conférence nationale sur l'apport des religieux sur la question de la capture du dividende démographique. Et là, il y avait le ministre qui était là et qui était venu saluer le travail du CRSD, qui était venu encourager le CRSD vraiment pour son appui sur les questions de promotion de la planification familiale. Je termine en vous invitant à regarder cette vidéo.
So much.
Donc, je vous invite à regarder cette vidéo qui vous donnera un aperçu sur l'ensemble des activités qu'on a pu organiser avec les religieux. Merci. Le prochain slide.
Thank you so much, Ibrahima. Thank you so much for that discussion. We really do appreciate all of the insights that you are bringing, especially with working with the faith leaders and turning their narrative into one that could be turned to positive promotion for child spacing. I know in the past they've been very reluctant and there've been a lot of misinterpretations of scripture. The way you have been able to couple the faith leaders who are very influential with a very high impact strategy of having them coming onto the mass media and the social media is great for us to learn. Thank you so much again, Wilma and Ibrahima. Let us move on to our next, and as we continue on with our presentations, please remember to enter your questions in the chat box and we will get to them at the end of the session. Next, we will hear about theology, ethics, and public health, a conversation about the social norms change and family planning in Malawi with 3 panelists. Emily Chambers-Sharp works as a senior technical advisor with World Relief, where she supports the SCOPE project. She previously was the president and CEO of the House of Mercy in Charlotte, NC area, which is a ministry of the Sisters of Mercy to people living with HIV. She has held various senior management and technical roles in humanitarian health, nutrition, and community-based HIV programs. Reverend James Tenga has served in the Anglican Church since 1985. He served as president of the Anglican Family Network, chair of the Anglican Council of Malawi twice, and chair of the Malawi Council of Churches. He currently serves in the Grants Committee for SIM and is a member of its board. Cecil Ngoni James Tenga is a public health researcher in infectious and liver diseases, digital health systems, bioethics, and health policy. He is also a bioethicist and is involved in faith-based initiatives around the world within the Anglican Church Communion, in which he's a lay minister and clinically trained in health chaplaincy. Over to you, panel.
Our presentation today is a response to a 5-point ethical framework put forward in the paper, Bringing Ethical Thinking to Social Change Initiatives, Why It Matters, in Global Public Health. Our aim is to help us all think about ways we could apply theological, ethical, and local wisdom to any of our programs in global health and consider the complex reality and important balancing work that we have to do, especially in family planning. Lastly, I'll present from World Relief a case study of how we apply this theological and local thinking in the development and adaptation of the Families for Life program in our USAID-funded program called SCOPE.
Childbearing, health, well-being, and wholeness and flourishing have always been preoccupations of religions and theology. In John chapter 10 says that Jesus came so that all may have life and have it abundantly. Beginning with Genesis 1, be fruitful, multiply, and fill the earth, on to Psalm 127, which says that one who has a quiver full of children is blessed. Bearing children is not just a biological reality, but it also a command, or rather an expectation that God has on people. Frustrating or desisting from having them is perceived to be not only unnatural, but also disobedience to God. With this in mind, it becomes clear how the discourse on contraception within and among faith traditions is fraught. All cultures and traditions have found ways of navigating the terrain while upholding religious norms and ethical norms. The spanner in the wheel has been the question of freedom and free will on one hand, and that of agency on the other. Free will is the way by which an individual exercises agency. But what informs that free will, and how is it inculcated? Slide 2. Within the church, catechesis, Bible study, and other teaching moments tend to be the site of the inculcation of mores and law. Liberation theology, using the pedagogical ideas of Ivan Illich, Paulo Freire, Marxist thought, and best Christian community Bible study, examines and interrogates the knowledge norms propagation and change through lived experience in context. As such, it leads to the shattering of monopoly of the elite and patriarchy, and gives agency to peasants, and in this case, to women. Gustavo Gutierrez, a liberation theologian, says, first, there is liberation from social situations of oppression and marginalization that forces many to live in conditions contrary to God's will for their life. But it is not enough that we be liberated from oppressive socioeconomic structures. Also needed is a personal transformation by which we live with profound inner freedom in the face of every kind of servitude, end quote. Slide. If one were to choose a relevant passage from the Bible for this discussion, the Magnificat would be the most ideal, not only because it is a song of a joyful mother of the Savior rejoicing with her pregnant cousin, but also because of the upending of the power differentials expressed in it. If the norms change interventions expected in family planning propagation are to succeed, a democratization of process and knowledge and agency of Malawian women is paramount. Change cannot be externally driven, neither can it be by the educated and the powerful. It is if it is to be for good and for the flourishing of society. Money-driven interventions have demonstrated their wastefulness over and over. Power-driven ones have produced church-blessed untold harm in political and legal enactments that have denied choice and agency and well-being to women with untold loss of life. Local agency utilizes not only local knowledge and language with the right cultural sensitivity, but it also empowers them while ensuring sustainability and human flourishing. It takes norms change intervention, also known theologically as prophetic imagination, to achieve this. Such would be Jesus' intention of having life and having it abundantly.
According to the biblical narratives around childbearing, it is poignant that the incarnation of Jesus is an apt illustrative image for considering the ethics of reproduction. Just like one might have to grapple with the notion of a divine being and a human conceiving without physical interaction, the traditional practices surrounding surrogacy in Malawi invite new insights into the dynamic and intersecting ethical realities of reproduction. In the previous section, we asserted that health and well-being are more than just a biological reality, but a cosmic expectation. Here, we extend that and suggest that these realities are socially conditioned, and as such, are subject to questions of justice and fairness, which are inevitably implicated. Our case study below will go into much detail about this. So to that extent, we start with two critical questions. The first one, what are the ethics underpinning the public discourse on reproductive health in Malawi? And the second one, how can the particularity in that country's ethical context be attributed to our efforts to advance public health? Next slide. Reproductive coupling is a continuum which has been masked by various social biological complexities. The result has been a simplification of scientific interventions into indigenous societies that fail to deal with those contexts as nothing other than objects. The objectivity of the public health regimes presupposes what post-colonial scholars have deemed hegemonic settler sexuality. This is the idea that reproductive coupling is always heterosexual, always nuclear, always monogamous, and subjected to Judeo-Christian ethical norms. However, by zeroing in on surrogacy, we derive a much nuanced, subjective conceptualization of reproduction, which contrasts the one critiqued above. This espouses a more fluid sexuality, such as the possibility of asexual conception through a surrogate, the optimization of kinship versus nuclear family, non-monogamy, and subjected to intersecting social norms of culture, traditions, and political realities. Therefore, the answer to the first question posed earlier is an affirmative yes. However, it is one that resists the oversimplification of current public health regimes. Those ethics are informed by an overarching framework of Ubuntu, holding in dynamic equilibrium on all matters the rights of individuals and their responsibilities to a cosmic community. Next slide. So how does surrogacy offer a critical reframing that rectifies this oversimplification? And here I will talk about three cases of surrogacy. In the first case, a couple with infertility challenges approaches uncles who facilitate the recruitment of a surrogate. In the second case, a bachelor or a spinster approaches siblings and has a consensual agreement made prior to or after to adopt one of the latter's children to raise with full or partial custody. And in the third scenario, a young parent, particularly young teen mom, approaches family following an unplanned or planned pregnancy for postpartum support with either partial or full custodial responsibilities. In each one of these cases, there is a particular interest in wanting to extend the family through kinship. There is also the confidence that is taken together to make sure that couples, both autonomy are respected. And then lastly, the rights of the community and the responsibility to that community are guaranteed by making sure that reproduction and childbearing is done within a community setting with the community's needs in mind. Next slide. To conclude, family planning is a balancing act of ethical obligations in a pluralistic society like Malawi. Interventions ought to build on top of existing reproductive practices such as surrogacy, as they have been tested by the passage of time and have morphed to coexist with the modern world. In surrogacy, the public health regimes can find analogs undergirding that bioethics in a bidirectional exchange that adapts and bolsters existing care delivery systems while training all of its agents to determine the outcomes of our communities. We present a case study that makes such an attempt in the next section.
Wrapping us up, I want to introduce World Relief Scope Project and consider how we integrated these guidelines. SCOPE is a 5-year USAID-funded global health project that stands for Strengthening Community Health Outcomes Through Positive Engagement. And it aims to really address key drivers of maternal and child morbidity and mortality at the community level in 4 countries, which include Malawi. We want to increase access to and utilization of health services that are critical for women and children, to ensure healthy behaviors and to improve the quality of health services provided, as well as strengthening links between communities and facilities. In the midst of this, we have multiple interventions that are listed on the slide here, including specific actions aimed at outcomes such as modern contraceptive use, the proportion of couples who discussed family planning within the last 12 months, and the proportion of women who are counseled on family planning during the postpartum period. One of the program approaches that we've decided is a couples-focused intervention to discuss family planning and make joint decision-making about this possible. This program model in its typical rollout has always begun with a contextualized beginning with faith leaders and other stakeholders, and then a recognition of couples from within local faith communities who are able to bring together peer groups of other couples within their communities, or perhaps from the same faith networks, in small groups, so that they can meet for 10 sessions and open up dialogue about difficult topics. In that paper we mentioned at the beginning, I talked about the ethical guidelines they brought up, and there were 2 frameworks in particular. At the moment, I'd like to highlight those around decision-making while we implement programs on the right. We're familiar with these concepts like do no harm, which helps individuals and communities attain good health and minimizes risks and potential harm. Respect is about recognizing that every person matters and that we need to treat people accordingly. We support others to make their own decisions whenever possible. Fairness is about prioritizing when resources are not enough to provide for all in a way that makes sense and is acceptable to a community, and supporting those who are entitled to something to actually have access to it. Reciprocity is about helping each other and acting on the special responsibilities or roles for a particular professional expertise. And solidarity can be about working together to show that when there is a need to be met, our commitment is to strengthen both individuals and the broader communities in which they live so that they can care for neighbors, friends, families, and relations. So here are some of the ways that we wanted to integrate these frameworks within families together. For doing good and doing no harm, we recognize that people's desires around fertility and family planning vary. For some, it will be about limiting family size, as is the case in Malawi for most of the people that we're working with. For others, it is about infertility. And for some, it is about spacing and timing pregnancies. One example that we utilized in our curriculum was including a story about a couple making a decision together to stop having more children. We also included a role play about a couple meeting with a healthcare worker and interacting with them about limiting their family size. So we gave some examples, and perhaps there's more work to do still around things like infertility. With respect and fairness, we updated games and activities that explored power dynamics and gender roles, approaching these subjects indirectly through those experiences that the couples would share as peers together, rather than us providing a rubric for what couples should exactly think or do. For reciprocity, we brought in a local expert, community health workers, or community-based family planning distributors, and allowed them to be those who spoke directly about the more technical things, like the actual contraceptive methods, and letting the couples' peer groups focus on sharing things in an everyday language. In terms of solidarity, we include time and space within the revisions for the couples and gender groups to have dialogue, to explore their values, to explore the values that they find in their faith communities, and make plans together about how these would result in action for themselves, but also for others in their community. We link this to the activities among faith leaders for social mobilization and social accountability monitoring. Lastly, the couples groups are gathered and recruited through faith institutions, as we implied in the section on theology. And in these groups, they challenge patriarchy and oppression. And we shift away from using sacred text as a how-to, but rather as a way for folks to explore and integrate their values related to reproduction and what it means to be a couple in their context. We value insights through idiom and illustration guided by our colleagues in Malawi. For example, the Malawi team has put in a strong baobab tree illustration as a metaphor extending through all the lessons about mutual trust, communication, and strength that comes from that kind of a relationship. So today, this is the new Families Together theory of change. It's based on priorities from USAID and the global health perspectives. It needed to integrate emerging evidence from social and behavior change communication programs and family planning, but also from evidence-based psychological theories for couples and individuals. We focused on improving the nature of and the communication between couples as that two dyad group, and developing mutual trust and exploring power and satisfaction in that dyad itself. But as a group, as a whole, we supported transformation by exploring faith values together that might relate to family planning or healthy behavior and good relationships. And then facilitating interactions around all of this through role plays and stories and games and discussions. And that process has resulted in giving people the option to have joint decision-making about sexual and reproductive health that is aligned with their values, and that they can initiate or maintain family planning methods, some of which might choose modern ways, or others who might be able to find other articulations or expression of what works for them in reproductive health. And importantly, we increase mutual support in the dyad relationship of the couple. Our balancing act was to bring together these theories and global health practices, but also lift up the voices of people in Malawi and ensure that what we are doing practices ethics and lives out our theology, that we're doing no harm while we work to make changes that are actually quite intimately held. These are tensions and they exist with donor desires, and the tensions also can be with the outcomes that are necessary to prove that we need to steward resources well or deserve to have the opportunity to get more funding. And I would say many of us in global health contend with these very tensions. It's important for us to work out and plan for these kinds of ideas, even while we're working towards health outcomes. We at World Relief are learning as we go to center ethical, theological, and local guidance into this public health practice. Thank you.
Thank you so much, Emily, Reverend Tenga and Ngoni. I think that was a very helpful discussion to be able to bring to, into mind how the faith systems or faith actors can be able to look at issues that we've been grappling with that have previously been seen as an ethical quagmire. What I really took home from that and what was really insightful for me was the way that your examples demonstrated and highlighted context-specific ways that we can work to bring the idea of family planning and reproductive health to the fore and to have it fit into our culture as Africans, especially looking at things like kinship, which are quintessentially an African thing, and to be able to, in that same space, look at some of the downsides like patriarchy and oppression and challenge that within the faith systems. I think that was very helpful for all of us. Thank you so much again. Next, we're going to go on and hear about more of the SCOPE projects, Family Life Education Model from Dennis Mwangela, who is the African Director for Integral Mission, Implementation and Integration with World Relief. Welcome, Dennis.
Thank you so much, Evelyn. Good afternoon, good morning, good evening to colleagues and fellow participants. I want to build up on what my colleague Emily just shared earlier by continuing with one of the aspects of our scope programming in the 4 countries that she made reference to. Next slide, please. That's the overview of my presentation. I'm going to focus on the family life education. Next slide, please. So part of our programming through scope is to contribute to the reduction of preventable maternal and child morbidity and mortality in selected districts in the 4 countries. Next slide, please. And one of the key actors in this process of delivery are the faith actors. As you think about the various objectives of access, quality, and demand, World Relief is working through different actors to deliver information and services to the woman of reproductive age and the caregivers of children under the age of 5. As you see on the bubbles on the left, each of the bubbles represent a core work stream and set of activities. But for the purposes of this presentation, I'll focus on the middle bubble, which is the faith actors. Next slide, please. Prior to the family life education, whose goal is to equip faith leaders about sex and reproductive health communication, we engaged communities as well as key faith leaders through a tool which we called Making Our Communities Better. The tool was essentially helping faith leaders to understand the mindsets and the beliefs and value systems that exist in our communities that sometimes prevent us from adopting healthy behaviors in as far as sexual and reproductive health is concerned. Then after those initial trainings, that's when we began to integrate family life education amongst faith leaders. Next slide, please. But what is faith life education, family life education? Basically, it is a curriculum that sensitizes faith leaders, their spouses, and their key members from their congregation to reproductive health and health messaging and its use among its communities as well as their own congregants. The training covers content in 5 workshops, one workshop a week, and it's done for 5 consecutive weeks. And during the last workshop, faith leaders make commitments of some of the actionable plans that they will be able to follow over the period of a year or so in making sure that the communities are engaged in understanding family life related issues. Next slide, please. What you see on the screen is the content of the curriculum and the workshop that are conducted. As you observe, as I said earlier, there are 5 workshops, each one of them focusing on a specific area. I'll just give you 30 seconds just to go through the workshops. As you observe, we have sections on myths and facts, but we also have role plays. This has given opportunity for faith leaders to talk about issues that are affecting them in as far as family life is concerned, including the controversial issues of family planning. And they have had the opportunity to unearth some of the facts and myths around family planning, as well as family life education. And the use of role plays has been seen to be very critical in enhancing understanding of these messages. Next slide, please. So this curriculum is not completely new. It has been used in the past in other USAID funded projects, but it went through an adaptation, and this adaptation included broadening the intended target and audience. Initially, it was for youth and young people, but the contextualization process included us in including faith leaders in the process, so that when they are equipped to communicate on these sensitive topics, they are able to reach everyone and anyone within the areas of influence. The goal that the curriculum will be able to ensure that the youth and the young adults are able to hear from everyone in the community, from aunts, from uncles, from mothers, from fathers, so that the family life education is held from anyone and everyone in the community. But also another key adaptation was that the inclusion of Muslim scripture and word to ensure that major faith in the project areas are included in the implementation. Next slide, please. Some of the key things that happened in the process was that the curriculum was translated into several languages after having key meetings with national leaders from different countries. In total, over 81 leaders in each country were engaged, so that we discussed issues that could be included in the curriculum from a faith perspective. And this proved to be a very, very important aspect, because most of the aspects that were difficult and not easy to discuss from faith perspective were discussed at that level and were included with the permission from the key leaders in that regard. And it was translated into 4 languages, 2 in Kenya, 1 in South Sudan, and Chichewa in Malawi. These translation helped so that pastors and faith leaders could understand the use of the curriculum from their own languages, as opposed to using other languages. Next slide, please. Some of the key learnings that we have had on the adaptation process is that pilot testing with representative faith leaders was a very valuable step, because it allowed us to learn and adapt the content, even the use of the right words in each of the contexts in the community. But also the other issue that we learned through this was that if we spend time to celebrate these faith leaders at the conclusion of every training that we're doing, the process of graduation that we had, which included actionable plans, helped the faith leaders with a good send-off to the communities when they were asked to go through and begin to train others in the community through this celebration that was done at the end. They were encouraged to be able to engage their communities better than when a graduation was not done. A graduation acted like a send-off session that helped pastors and church leaders to do that. We also used an opportunity to integrate COVID-19 vaccination messages in Malawi, where at every point where the training was done, we had COVID-19 vaccination messages integrated, and quite a number of people used those centers as vaccination centers when the vaccination campaign was happening. So that type of integration also helped to achieve better results of other things that were accomplished during the training sessions. Next slide, please. Next slide, please. We also have a kind of a monitoring and evaluation framework. So we have two aspects of M&E. The first aspect is where data that is collected during the training, and the other aspect is data that is collected after the training. Next slide, please, as I conclude. So to date, we have trained over 4,000 faith leaders and across the 4 countries, and 14% of those are female, and these are from both Christian and Muslim faith. And so far, the results are pleasing, and we are looking forward to seeing more and more faith leaders engaging with the young people in their communities in family life education, which includes family planning. Thank you so much for listening.
Thank you so much, Dennis. That was yet another very useful presentation with guiding us on how to use this curriculum. I really enjoyed it, especially because they were showing how we can guide the faith leaders in a relevant and responsive manner, and taking into consideration local realities and using the structures that are already in place. Thank you again so much, Dennis. We are going to move on. Next, we're going to hear about tools for transitioning a maternal child health intervention to church ownership from Dr. Kabezas and Dr. Sempore. Dr. Jadida Sempore is the manager of program support at Compassion International. She's a medical doctor with additional training in public health focused on nutrition. She served as a subject matter expert for mother and child survival for 10 years and helped develop a variety of implementation guide and action plans. Dr. Diana Kabezas is a monitoring and evaluation specialist fellow at Compassion International. She resides in the US and has devoted her research to examine risk and protective factors for maternal and infant health outcomes. Her passion in this field motivated her to pursue and complete a doctorate degree in Family Science and Human Development from Montclair State University. Welcome, Dr. Jadida and Dr. Diana.
I am Jadida from Compassion Burkina Faso in West Africa. I am glad to present on how we are working with local churches to move from NGO-initiated intervention to church-owned intervention. Next. Early childhood survival and development are the first 2 steps of Compassion International's holistic child development program. It's implemented by evangelical local churches in partnership with Compassion. The program targets pregnant women and vulnerable children, along with their mothers, through a home visit and group approach to save children's life and put them on a path to healthy development. Awareness raising on practices that promote healthy child growth and development, as well as the creation of economic conditions for economic empowerment among mothers, underpin the activities which are curricular, health, and psychosocial. Compassion has been providing funds for survival for the past 10 years, and now Burkina Faso's national office is seeking to transition survival intervention to the local church ownership. Transition to a local church ownership is needed because it builds church capacity and sustainability for the church to function on its own. The picture shows the church combating child malnutrition. Mothers come to the churchyard to nourish their babies who are malnourished, and then they will continue on their own. Next. Transition to church ownership started with the selection of the church to implement survival. The selection criteria are reputation in the community, the church commitment to mobilize local resources, the church leadership commitment to child development, and the supportive statistics related to mother and child health. Running the intervention in a developmental mindset is key to a successful transition. This means that the church and compassion partner together through a sustainability plan. Next. What can the church do if compassion stops funding? 3 options are possible. First, the church can keep implementing survival as it is with 100% of local resources. This means that the church would have been well prepared and set its own vision. Option 2, the church decides to implement a customized survival programming with 100% of local resources. That means the church is limited and cannot serve mothers and babies as it adds with compassion funds. 3, the church decides to stop survival implementation. Next. For an effective transition, which means the church decides to pursue the vision of serving moms and babies in its community with 100% of local resources, it's important to develop a participatory approach which involves the church in all decision-making related to survival programming. It's important to define with the church maturity milestones towards self-supporting programming. It's important to build the church-specific capacities in community mobilization, resources mobilization, and in mothers and babies' needs identification. Now, my colleague Diana will take you through a tool designed for survival program transition to church ownership.
Thank you, Jadida. Now that we have seen how Burkina Faso is preparing, I want to show you an assessment tool that we have developed to help in this process. This tool is based on external literature and resources as well as internal needs and values. The literature highlights key components related to the program, the organization, and the community that influence the success of transitioning programs to local ownership. In particular, research on community health worker programs revealed that ongoing training, supervision, community integration aids with program success. On the organizational level, research identifies that early planning and clarity on transition should be prioritized to promote sustainability. Now, the literature also shows that community participation and support are important for building local ownership. In addition to the external research, we identified compassion priorities that we felt were important to assess as the church prepares for local ownership, including the ability to mobilize the necessary resources and to use data to make decisions. Now, based on these elements, we designed a tool to assess the church's readiness for transition. Our transition readiness assessment was inspired by the Community Health Worker AIM tool, which was designed by the MCSP to identify gaps and optimize performance for community health worker programs. However, our tool is designed to help churches self-assess their progress towards transition readiness assessment. Now let's take a closer look at our transition readiness assessment tool. And the Transition Readiness Assessment tool is to be used by frontline church partners from the program's inception to periodically assess the church's readiness for survival ownership. Now, there are 2 parts to the tool, as you see on the slide here. The first part allows the churches to rate themselves on how it is functioning in different categories and to provide rationale for their rating. The second part helps the churches to plan how to improve areas that are below the benchmark. Now, this plan includes what action is needed, staff members responsible, and resources needed, among others. Now, through continuous self-assessment and action planning, our hope is that churches will incrementally increase in their capacity in these areas. We plan to aim for a church to attain the highest rating before they transition. Now, the categories that the churches will assess themselves in are listed on the right side of the slide. Now, these elements, which were identified in the literature and compassion values, serve as key components to promote local ownership and sustainability, which include the implementer supervision, community involvement, local resource mobilization, and other categories that may foster improved program quality and successful transition. Now on this slide, you can see part of the transition readiness assessment tool. In this example, we are viewing one of the categories, which is local resource mobilization. Now there are 4 descriptions of where an area might be for an element: non-dysfunctional, partly functional, functional, and highly functional. Now the church will read through these 4 levels and identify which most closely describes their current state. For example, for this category that we're viewing, local resource mobilization, if a church has developed a strategy to garner additional funding for survival, but has not yet implemented the strategy, then they will rate themselves a level 2, which is partly functional. Now the church can perform this self-assessment regularly as it prepares for transition. Now the church enters their self-rating and why they selected this rating. After they have rated themselves in all areas, the church will move to the second part of the tool, which allows the churches to review the rating and plan on how to address and increase the rating if they fall below the benchmark. Now, the plan includes a space to identify the specific activities, the staff members involved, resources needed, as well as a timeline. Now, this journey has been and continues to be a space of learning. We know that these plans and tools are not complete or perfect, and we look forward to continuing to learn and iterate as we transition survival to church ownership in countries around the world. Now, 2 key points that may serve helpful are to engage community partners for feedback and to align literature as well as standardized practices for tool design. Now, we will be pilot testing, revising, and preparing for global rollout of these tools and new transition processes in the coming months. Now, our hope is that the more intentional when it comes to planning and assessment of a church's readiness for transition, it will help empower and equip the churches to continue the excellent work that they are doing to help mothers and infants survive and thrive. Now, we are grateful for the opportunity to share our learning today, and our hope is to get feedback from our listeners from their own experiences on transitioning programs to local ownership. We would be glad to hear what elements our listeners have prioritized to build local ownership and sustainability, or how they have measured the effectiveness of the transitioning process. Now, we look forward to engaging in discussion. Thank you very much.
Thank you so much, Dr. Jadida and Dr. Diana. That was another very practical example of how transitioning can be done in a systematic manner. And it addressed one of the questions that we usually have, is whether local actors do actually have the capacity. And this presentation was great because we could see how one can start with lower capacity and assess themselves and have a plan to increase their capacity so that when they do transition, they're able to have a successful development program and a sustainable one. Thank you so much once again, Dr. Jadida and Dr. Diana. We have come to the end of our presentations, and I would also like to thank all of our presenters today. I think all of you have been bang on in terms of addressing the theme of localization, and you've been able to show a recognition for local skills, for locally driven solutions, and appreciation for the knowledge that we as local people and local actors do have. What is really standing out is that the interventions that you're putting forward, or the approaches that you're putting forward, are very responsive, and that they're being delivered in a manner that is acceptable to the people, and that is utilizing their knowledge and their skills, and it is being put through in avenues or forums that are very accepted by the communities and that are of high impact. I think we have gotten so much insight on how to tackle very difficult or ethically problematic issues or sensitive issues that have been seen to be an area where the faith cannot participate in. But you've shown us that we definitely can, and we can do this successfully. Thank you so much, and we appreciate all of you. We are now going to transition into a session of question and answer. Please put your questions in the chat box and we shall get to them. And the speakers, please be ready with your cameras on so that we can get into the questions. Thank you. I'm going to go to the first question, and this is for Troy and Nkatha. The question says, I am a strong supporter in principle of localization of development. sometimes called decolonization. It is a worthy rallying cry. What I would like to see in specific examples of what would be different if local organizations, especially FBOs, were at the helm. This is a question from Nancy Harris.
No, thank you so very much for that question. What we've seen, I think, in terms of what we've seen here on the ground is a pretty significant difference. I think our aim for development in many ways or community is for personal health and community health. And I was actually just writing some notes down here for this, is that I think it resembles physical health and what relates to community health and the wholeness of the individual and the wholeness of the community. One is that I think physical health means that I and my body have my own mechanisms for sustaining the systems of my body within myself. I think that's the same for a healthy community, that it has mechanisms within itself to be able to sustain and support itself as it relates to the community. A healthy body is able to have some resistance, be able to recover from shocks to the person. I think it's the same as for the community as well, being able to do that on their own. Another is a healthy mindset, being able to take responsibility for my own health and not looking at it being someone else's responsibility for my own health. And so therefore I'm taking responsibility for my prevention, for good hygiene, habits, and those types of things like that, versus a mindset of looking that this should come from somewhere else. I think that's healthy for an individual, and I think it's also healthy for a community. The other part about this, I think, and I think there's a number of facets of this, it relates to sustainability and continuity. Oftentimes when you have the internationals coming in or these proxies coming in, they're operating at program cycles, opening programs, coming in for the program cycles, and pulling resources from the community and competing with the resources that the community could use for itself to build its own solutions there. And then it closes out and it goes through those cycles. As far as when there are faith-based organizations, which are permanent institutions in community, they offer sustainability, continuity, they have the trust of the people, they're connected to networks within the community so that they can spread out what they're doing and take it somewhere beyond the project cycle. And as we develop the economic capabilities, savings groups, businesses, and those other components for development that are able to come in, it also helps with sustainability. So I'll stop there, I guess, I'm hoping that answers the question somewhat, or you can elaborate if I missed it somehow.
Thank you so much, Reverend Troy. I think it's very important for us as the faith community to come out clearly on how our approach is different and it's not the same as other organizations. And I think you've articulated that very well. Thank you. We'll go to our next question, and this question is for Ben. In Ghana's story, or in Ghana's history rather, and relationship to faith-based healthcare is unique or similar to other parts of Africa. Let me repeat that. Is Ghana's history and relationship to faith-based healthcare unique or similar to other parts of Africa? Are there the lessons learned applicable to other countries as well?
That's a great question. And the reality is, there's very little work or historical research of this kind out there on other countries. So my honest initial answer is, I don't know. But I think, I guess, as I said before, that my book serves as a reminder of the gaps, the genuinely hidden histories and suppressed voices of millions of people. Because by unearthing a part of the neglect, you illuminate how much there is out there. So that would be my first kind of most honest answer. I think what my book does do is it looks at how the funding streams from Germany and the Netherlands, they certainly did do that in a lot of other countries. I think Ghana was a unique focal point. There was a lot of Dutch doctors, especially, that ended up working in Ghana. A lot of streams of funding that were particularly targeted at Ghana. But if you look at, the Lancet work that was published in 2015 by Jill Olivier and lots of other people on faith-based healthcare in Africa, you can see that there are incredibly high levels of it across the continent. I think they looked at, Uganda, they said it was 50% of the infrastructure was faith-based. I think Kenya might have been 40%. And there is work on some of that. So Shane Doyle has done some on Uganda and shown some really interesting things. For example, he showed that in the 1920s and 1930s, maternal and child health in Uganda was as good as it was, or not better than it was in England and Wales, because Catholics and Protestants were working together on it. It was one of the few really effective ecumenical initiatives, and it rocketed the capacity of the country. So that obviously didn't last, and there were lots of changes across time. But again, you look at the shifts away from certain kinds of investment, certain kinds of focus that you can see in Ghana. So my guess is, yes, there will be lots of common patterns, but I think there's a lot more work to do to really tease those out and identify exactly what is unique and what are things that we can see much more widely.
Thank you so much, Ben. I think I had the same question in how does it compare to Kenya? And I think why we don't know is because we don't know our histories. We're so used to learning about American histories or European histories as the gold standard for healthcare. So it's really I'm really glad that you're coming and showing this, but I'm also a little bit upset that you're English and that we didn't do this as Africans and lead it. So, but well done. We're really doing this. To you, Nkatha, how are we different? How are we as FBOs different in this discourse? And how are we going to showcase our work and our uniqueness so that we don't keep ending up here where we don't know our own stories and we're not shining?
Well, I think, thanks, Evelyn. I think one of the things that has been said of our work, we do what we do and we do it very well, but we haven't taken time to document what we do and how we do it. So I think one of the things that we can do very well is documentation. And thinking about working between the Global South and the Global North, one of the places where we can collaborate quite effectively is supporting one another in documenting what we do. Sometimes I don't want to say we are shy, we are humble. It's humility in not talking about what we do, but it would be important to document what we do and how we have done it so that those that come after us can learn. I'm reminded of the example of COVID-19 and the work that was done between the Global South and North and the things that we learned from each other. We were all facing the same problem, requiring the same, almost same solutions. And we would talk to each other and ask, what do you need? How can I help you? What should we do? So if we can document what we do and how we are doing it, I think it would be a long way. It would help a long way, especially we as a faith-based, because we have a lot of points of convergence as organizations. Yeah, thank you.
Thank you so much, Nkatha. I also agree with you wholeheartedly. My background is monitoring, evaluation, and learning, and I know completely that we don't tell our stories enough because we do not document. I think it has something to do with the faith, this humility, or we just want to hide our light underneath. And I think there's even a story in that in scripture that we need to shine as bright as we can so that we can learn from each other and can showcase to the world so that when the histories are being written, our story is out there. Thank you so much, Nkatha, for that response. I'm going to go to the question, next question, which is for Dennis. It asks, do you have any recommendations for working with mixed group of faith leaders with such delicate subject matters such as reproductive health, where there are many women represented in the faith leaders? That's a question for you, Dennis. Please go ahead.
Thank you so much for those two important questions. Let me start with the second one. Our data from the field is showing that over 44% of the participants during the workshops for faith leaders that were being prepared to go and do family life education in their communities were women. So there was a large group of representation of women from faith communities that were trained as faith as family life educators. In terms of engaging with mixed groups, the process that we followed at the beginning involved two key steps: in engaging groups of faith leaders individually. So we engaged those of the Christian faith and those of the Muslim faith individually, because even in some countries, those of the Muslim faith have different, I wouldn't call them denominations, but they have different sects within the Muslim faith. So we had to engage each one of them separately because they take different stand on different aspects or different issues. And that proved to be very, very helpful because they would open up and we would discuss these issues openly because it was that closed space. After engaging most of those individually and knowing their positions and knowing where they can be engaged and where they cannot be engaged, we brought them together at national level or sub-county levels and talked now with both groups together. You'll be surprised that most of these faith groups agree in many, many things in as far as family life education is concerned. The only aspect that was a little bit contentious was family planning methods. People agree the importance of child spacing, they agree on the importance of family planning, but it's the methods that where there were differences. And there wasn't a lot that we could do to force faith leaders on some of those, but the goal was for us to make sure that we engage and they allow us, or they allow themselves where they can, to share these methods that are available to their congregants or to the people in the community, so that people must make their own decisions. Some of the faith leaders were open to that, some were not. But the key to engagement is engaging them individually, and then at a later stage bring them together so that they can look at these issues and discuss openly together. Thank you.
Thank you so much, Dennis. Can I add a follow-up question? You said that you had 44% of your participants in the model being women. Was this deliberate? How were you able to reach so many women? Because religion or the religious spaces have typically been quite male dominated.
There was translation in the background, so I didn't get the question very well.
Let me repeat that. I was asking a follow-up question on whether you mentioned that there were 44% of your faith leaders were women, and my question to that was, did you set out deliberately to get quite a lot of women, or how did you do this? Because typically faith spaces or religious spaces have been very male dominated.
Yeah, it was intentional from the beginning when we were having this conversation with church leaders and leaders from the Muslim faith. We mentioned the need to engage young people or to talk about family life education from both angles. So we encourage participation of both men and women. And in most cases, the participants to the workshop came as a husband and wife. And that helped to increase the number of women because in most of these faith institutions, counseling for marriage and other aspects to do with family are actually done by couples. So intentionally from the beginning, we encourage the participation of women. We had, in some cases, from each institution, we would have 4 participants, and we intentionally said 2 should be men and 2 should be women.
Excellent. That is a really good lesson, to be intentional about getting women and more women in this space so that they can reach out to their audience. I also really liked the way that you were able to bring together the Muslims and the Christians in a learning space that was safe, and they could be able to discuss areas of convergence and also just accept the areas of divergence. Thank you so much, Dennis. I'm going to go to the next question, which is from Ibrahima. It asks, we spoke about radio, TV, and social media. How can local media help the principle of locally led development? Does it give voice to the local leaders? how can that affect attitudes and policy?
Merci beaucoup et rebonjour à tout le monde. Vous savez, au Sénégal, la radio est le média le plus écouté. C'est vrai, on a des télévisions, il y a la presse écrite, il y a les réseaux sociaux, mais le taux de pénétration de la radio est beaucoup plus important que tous les autres médias. C'est pourquoi on utilise la radio. Et le charme avec la radio, c'est qu'il y a de l'interactivité. Quand le leader religieux, par exemple, anime une émission, les populations peuvent directement appeler à la radio pour poser des questions sur leurs préoccupations, par exemple. Donc, c'est ça. Et l'autre aspect, c'est que ça se passe au niveau local. Les autorités locales, les maires, par exemple, au Sénégal, ou présidents de conseil départemental, médecins, chefs de région, infirmiers, sages-femmes, écoutent tous la radio. Eux aussi, ils interviennent à travers ces émissions parce que les émissions qu'on organise à travers la radio, il y a un leader religieux qui est désigné et qui porte l'argumentaire religieux, mais à côté de lui, il y a toujours un médecin, un sage-femme ou bien un infirmier qui est désigné pour appuyer l'argumentaire du religieux. Donc, ce qui fait que l'information passe vite parce que c'est donné par deux spécialistes, un leader religieux qui est là, qui est écouté, un médecin, sage-femme ou infirmier également qui appuie. Et là, les populations consomment sans problème les informations qui sont fournies par ces deux-là. Donc, c'est pourquoi on a préféré quand même miser sur la radio parce que les résultats sont probants, les résultats sont importants et voilà, l'effet est là. L'effet, on le sent tous les jours. Si je prends par exemple la région du Sud ou bien le Nord, Matam, où il y avait un taux très élevé de mortalité maternelle, aujourd'hui, ce taux-là a été réduit. Et cela grâce à l'utilisation des pratiques de la planification familiale. Donc voilà, un impact qui est là, qui est réel. Le taux de planification familiale est élevé grâce à ces actions de communication de masse qu'on est en train de mener sur le terrain. Je laisse peut-être Wilma pour des compléments.
I think that Ibrahima has covered all of that. And I just wanted to add that, you know, it's been a journey with the religious leaders and their social media, their radio, and their television appearances. They've really been able to adapt to these mediums and really be able to target their messages. And in addition, we also do it in the local languages, Wolof and Pular, Serer, in addition to French and Arabic.
Thank you so much. It's the same here in Kenya. I think the radio penetration in Africa is very great. Just about everybody has a radio, so it's a great strategy. Thank you again. The next question is for Reverend Tenga. And the question asks, is promoting a nuclear family to be considered a product of hegemony? Is patriarchy equivalent to oppression? Does the FLE from the Agency of Responsible Fatherhood in Programming, does FLE include Agency of Responsible Fatherhood in Programming?
Well, I hope I'm loud enough.
Yes, we can hear you.
Okay, that's right. Well, it's just, I would say yes, because the nuclear family, as understood, at least by me, within the context that we are in, which is just me, my wife, and my kids, is something that is foreign to most of our cultures, at least within Malawi. And so to that extent, is the, shall we say, an understanding that's coming from without, primarily from the West, and building that it's just my decisions and mine alone. But most Africans and most Malawians know the pressures that are upon them from the extended family. When are you going to have children? Oh, how many children? Well, when is the next one coming? So there's always this engagement of the totality of the group. So there's that part of it. And then that's one. And then the question about patriarchy. And patriarchy certainly is related to oppression, because the decisions tend to be male-dominated, male-oriented, and at the expense of the agency of the woman and the participation in that particular decision-making. So there is that oppressive kind of thing. Sometimes people confuse matrilineal and matriarchal, or patrilineal and patriarchal. Well, even in matrilineal society, at least in my experience in Malawi, the matrilineal societies, which are kind of inheritance and power comes from the line of the mother, the woman, but really the decisions are still being dominated by the males. And in fact, this is why in the little thing I mentioned, Elizabeth Fiorenza, Schussler Fiorenza talks about kyriarchy, really then moving it from just being just the males, but to those that have the dominant power in the decision-making and the influencing of the running of that society. So those are some of the things that are related to that. I'm not sure whether I've got all the question. I think those are the two ones that are, I think, oppression and that. So the critique of where power comes from and who decides what's going to happen and what's not going to happen and what agency each one of them has tends to be patriarchal.
Thank you so much, Reverend. I think the last part of that question was, does FLE include agency of responsible fatherhood in programming?
I think for that one, Emily's not present, but I know Dennis works in the same program, so I wonder if he has more of an informed expert opinion. We don't want to speak to something that might be what we think it is, but if Dennis, if you're able to speak to Emily's slides, or if Emily, if you're around, that'd be helpful.
Yeah, maybe just before that is that even though we were emphasizing the agency of women, we were not ignoring the agency of men and the participation in it. But that participation of the male, rather than being a dominant one, but being an equitable engagement within it. But Dennis can go on if he has an answer to that, because it's program specific. Maybe not.
Yeah, I was waiting for Emily because Emily is still here.
Oh, well, we on our screen we couldn't see.
Sorry, Emily.
Go ahead, Emily.
Dennis.
Dennis, I would actually defer to you for the family life education specific question, because I think you know that better, and that's the part that addressed fatherhood. So you can go ahead.
Yeah, so the current curriculum that we are using does not include the issues of fatherhood, because it's basically talking about how can faith leaders engage with young people and others in the community to talk about family life education that includes growth and development to the point where they are ready to get married. So the emphasis is not either on the man, the fatherhood or motherhood, but the emphasis is preparation of young people on this journey to marriage that starts when they are still young. So there is no emphasis on either fatherhood or motherhood, but just preparing of young people.
Thank you so much. I'm loving these conversations. I think they're great because it's talking to who we are as Africans and how to localize these solutions to better help our development. Our next question is for Emily, and it says, how can your approach work or be replicated in other settings or contexts where people may not share such a nuanced understanding of the complex issues you spoke to? It is such a helpful path. How do we stimulate conversations around that? Emily?
Thanks. I think it's a question, and it's something that, yeah, can you hear me? Hi, I have unmuted. Are you able to hear me?
Yes, we can hear you. Yes, we can hear you. Go ahead.
Okay, great. Yeah, so I was just going to say it's a really interesting question, and I think there is a diversity of understanding about how theology or ethics or even our public health approaches might be applied to any kind of program. And I also think that while today we kept our talk at a level that's kind of academic and theoretical, that in the practical sense, if you're trying to implement a program and weigh these concerns, that the ways you can best do that are by ensuring that you are in dialogue with a number of different actors and being a very good listener. So can you, for example, discuss with a key different set of Christian leaders or other religious leaders in a given context and ask them about principles like those 5 guiding principles around doing good and encouraging agency, respect and fairness, reciprocity, solidarity. Find out where there is common ground on those values, and also where there may be differences, consider ways to, bring in, again, values that are sort of deeper or kind of more central than particular stances on issues or behaviors. And I think that the way I would say that is, I think generally we can agree with different faith, amongst different faith traditions, on values that respect the dignity of human life. That's a good overarching sort of central place where you can have these conversations. I think many of us would agree about, love being, an essential part of the nature of God. And if those things are guiding values that we can come together around, then how can we let those values, right, influence and impact the ways that we interact with one another, particularly when we have sort of conflicting understanding and priorities. For actors like donors, I think, it's not often going to be a subtle or nuanced conversation. Donors are going to be very clear about what their priorities are or what they're trying to get out of a program. And so what we can do to ensure that even within those donor restrictions, requirements, or demands, that we are also elevating to those donors the core central tenets or values that are of most importance to those people whom this project is seeking to influence. And by doing so, are we able to sort of turn or negotiate, a better voice and an inclusion of those who are meant to be influenced into the actual products that we have. I would say, I don't know that there's like a clear set of tools. It's something I've been engaged with in discussion with the authors of the paper from Georgetown that I recommended. And I'd love to talk with more of you guys, maybe in some of the breakout rooms, about things you've done to try to better integrate and weigh the different tensions between these concerns as you design and implement programs.
I just wanted to also add a small snippet to this, which is the issues we are talking about. Yes, there are nuances, but for something like bioethics of surrogacy, that's an issue that the UN is currently weighing because of the introduction of technologies, but also the equitable distribution of power between people who can access biotechnology to conceive as it relates to global economics. So many of you probably know biological or birth tourism, where Westerners are coming to the global South to conceive their babies. In Malawi, we've had instances of celebrities coming in to adopt kids here. So these are fundamentally, yes, nuanced issues, but are also new issues that have been unnuanced by the popularity of them and other international watchdogs in the secular space looking to introduce fairness and equality. So we did pander towards the academics of it, but there is ample right now, if anyone is interested, particularly on fertility issues, is interested in contributing towards that space. There isn't an international document protecting surrogate workers. And that's one thing that's, countries are trying to define. And the faith community, we have a whole legacy of being able to articulate moral positions in ways that are practical. And that could be a place where many of us here can apply our expertise.
Thank you so much, Cecil and Emily. Let's move on. I have a question for Jadida. It asks, how do you measure the success transitioning to local or church ownership after your program has ended? Jadida? I'll repeat the question. How do you measure whether the transition has been successful?
Okay, sorry. We have very poor connectivity today. So sometimes
Go ahead.
I close before I can follow. Thank you very much for your interest in our presentation. Just to say that to measure transition success, we need to sit with the churches and define the maturity milestones toward the transition we are envisioning. So when we do this at the beginning, we can, together with the church, move toward the monitoring and evaluation so we can gradually move to the transition. And when we get there, it will be easy to assess. So it's all about church and church implication at all phases of the project or the proposal. So we cannot say that these are what we are going to assess, but it depends on the context of each church and its community. Yeah, because the package of the program, the package that will be implemented depends on the church definitively and its community needs.
Thank you so much, Dr. Jadida. I think that is well understood. Our final question goes to Peter. And when we talk about localization, all we talk about is the impact on locals and building capacity of locals. But how do people in Zambia learn from work in Tanzania and Bangladesh? Is that one of the roles of the international NGOs?
Yes, this is very important. I think the whole concept of localization can be contextualized to mean South-South collaboration, sharing experiences. Today we heard so much about Ghana's experiences. I believe there are a lot of pointers and other value adds that other contemporary or allied Christian health organizations can learn. So I think that we should begin to look at the design and conceptualization stage of projects and programs to see how the benefits of such programs could be sustainable in terms of strengthening country and continental health systems. And I'm looking at organizations such as HAP. HAP is a platform, a consortium of all Christian health associations to institute some form of mentorship and support amongst Christian organizations. It will foster trust building, shared experiences, interest. And so localization probably will have to move out of the community, tribal context to look for it to appear more nationalistic, move beyond the bounds of community countries to make it more international. And referring back to Ben's book, where he drew a clear distinction between international health and global health. So we should begin to see how such conceptual issues, but international, amongst countries, between countries, could really promote shared experiences. And I think that it is time we're beginning to redefine mentorship, cooperation, partnership from the local level to simmer down up to denominational groupings, associations. And I think that is what organizations such as HAP and Christian Health Associations that bring denominations together, as well as Christian Connections for International Health, is. We should begin from bottom up and top down. That horizontal relationship is what matters. So to answer the question, I think it's rather a pointer for us to redefine partnership amongst us, between us, and see how we can cement the bond of trust, partnership, shared experiences, value add, promote, project our collective interest of promoting Jesus Christ healing ministry. If for nothing at all, COVID has taught us that diseases cross boundaries and shared experiences, shared capacities are necessary if we are to ensure holistic health and collective health security. I think that this is vital theme for us to contemplate. Localization by mentorship, by true connection, intense partnership, cooperation, and collaboration amongst all actors and partners promoting health and healing across boundaries, communities, continents, and the global level. Over.
Thank you so much, Peter. I think that was an excellent question and response to just wrap up our Q&A session, as it just circled back to what we've been talking about, which is recognizing that we as locals, as the Global South, do have expertise and knowledge to share, and that is also between ourselves and even with the Global North. Thank you so much for your answers. Thank you for the questions, participants. They've really shown that you're engaging with this and you're internalizing it and seeing how it can apply to you. So thank you very much for that. We've had a very informative, educative session. I would like to hand over to Mona now so that she can lead us into the breakout rooms. Thank you, everyone.
Thank you so much, Evelyn. Pleasure to have you moderate for us today, and thanks to everyone, all of our speakers. I learned so much. I'm like scribbling my notes. I can't keep up. I'll have to rewatch the session. Just so thankful for this conversation about how we respond as Christians to changing times. And before we transition to breakout rooms, I'd like to transition us with a time of prayer. So I'm going to ask you all to pray with me, and then I'll give directions for breakout rooms. So, Father God, I just thank you so much for this day and these speakers. Our theme first for this conference has been from Romans chapter 12, which says, "Be devoted to one another in love. Honor one another above yourselves. Never be lacking in zeal, but keep your spiritual fervor serving the Lord," Father. And so as I was writing some words down from some of our speakers, I think it really resonates from Romans that we heard about deliberately transferring skills to serve one another. Father, this reminder to help us tell our stories of why and how we do things, so God is at the center of that. And Father, help us remember to support one another to make decisions to strengthen individuals and the broader communities in which they live, and the importance of local languages and helping us have a posture of promoting health and healing, Father. So much more that I learned today, and I hope we all did, and I look forward to our conversations and breakout rooms, Father. I just pray that you continue to be with us in our conversations. In Jesus' name I pray, amen.
Amen.
Yeah,